All right. Hi, guys. It's Talysha and Jackson from Kinetic Therapies. We're back again for another Facebook live stream. And what we've decided to have a chat about today or tonight is based on a couple of the mentoring sessions Jackson and I have had with a couple of podiatrists over the last few weeks. And that is in relation to the importance of subjective history taking, and also how we can manage our client or patient expectations during the initial stages to help set us up for long-term success. It's probably easiest and makes more sense to start off with the subjective history taking, because that just naturally sort of flows into our managing expectations. So what are some of the things that you've sort of discussed with your mentees in the last couple of weeks as far as the subjective history and the importance of it?
Yeah, it's massive. Subjective history taking definitely is something. As I've gone on in my career, I've started to become more and more focused on and sort of start to really sort of almost pride myself on taking a really good subjective history, because when you take a really good history and you ask the right questions and you ask a lot of questions, ask the right questions, and listen to what they're saying, then you really can almost know what to do there and then and know the path forward from that point. Before you even do any of your assessments, you almost know what the answer is and what that person needs just from the subjective history taking. So it's really, really important to take a really thorough and good subjective history. Super, super important.
Definitely. And do you agree that oftentimes if we sort of shut up as a practitioner and let the person talk, a lot of the time they'll give us the information, or not all of the information, but a decent chunk of what they're actually wanting and needing from the consultation?
Yeah, absolutely. Just let them talk. So you might ask the initial question when you come in, be something really open-ended, like, how can I help you? Or, what's brought you in here today? Or something like, tell me what's your story, or something like that. Something really open-ended, and then just let them talk and don't say another word until they've paused and they've stopped and stopped for a few seconds, and then you can ask some more leading questions and then shut up again and let them let them talk. Yeah, you don't want to be interrupting all the time.
Yes. And I don't know, have you got up to that part in the online course where we cover how much time a patient can talk before they're interrupted by a primary care physician?
I'm not sure. I think that I remember the stat was it like 11 seconds or something like
Yeah.
that? Yeah.
So it's somewhere upwards of about 75% of people can't get through 11 seconds of giving their side of the story before they're interrupted. So, and that just falls massively short of how much time, especially someone with a chronic presentation, needs to actually tell us all the information that we need. Now, what do you think as far as questions that are probably a little bit outside of the box from what we were taught at uni? Like at uni, I know we were taught, like, as far as the subjective, objective history taking and the assessment, like there's the where does it hurt, how long it's been hurting for. What do you think are some other really important questions that we need to elicit or get the information from in the subjective history taking that actually helps guide our treatment?
Yeah, huge. Definitely the ones you are taught at university, and the typical sort of medical questions that you ask. They don't even scratch the surface really of what we need to ask people to understand what we need to do for them. So a big one where our strengths are in strength and exercise therapies is to take especially if you're implementing that into your practice, is to take a thorough previous exercise history, previous rehabilitation history, and previous practitioner history as well. So asking them, on previous practitioner history, asking them have you seen anyone for this problem before? And if so, what did they do for you? Did you like it? Did it help? And why or why not? And questions like that just go deep on their experience with their previous practitioner, or if they've not for that problem but another problem. So if they've had, say, a shoulder issue and they've seen another physio, for example, for that, ask them about that process and what they thought of doing exercises and things like that, and how it went, and whether it was successful and why it was successful or why wasn't it successful. Really go deep on all this stuff, and that helps to paint a picture in my mind of how we might need to approach the start of their rehab plan, and where we start them, and how we integrate exercise and rehab into their program by listening and understanding their response to those sorts of questions.
And even sort of expanding on that in relation to specific exercises. So one thing that I've come across quite often in the clinic are patients or clients with plantar heel pain or Achilles tendon pathologies. And quite often, if you go into some of the rehab side of things, like we've got our eccentrics and the high load eccentric training for plantar heel pain, like the Michael Rathleff protocol. And a lot of people, they'll say, oh, I've been given that before, it didn't work and whatnot. And often, I don't know if you find this as well, but in my experience, I tend to find that sometimes it's not necessarily what they've been doing that's the problem, it's how they've been doing it. And this can come down to the dosage. So I find asking them, even if the exercises that they've done before are ones that you're thinking of giving them, but what their exposure and their dosage of that was. So if someone they were only prescribed single leg heel lifts right from day one, and that caused a really significant flare in their pain, and they were told they had to do 25 repetitions 3 times a day for X amount of weeks, and over a day or two it just built up and it flared up, so they stopped doing the exercise. Like I find that sort of asking what their actual experience with a specific exercise, if they have been given it before, why it worked or why they feel it didn't work, and then sort of regress backwards. Because sometimes if someone's had an adverse experience with either a specific exercise or exercise therapies in general, that can create a little bit of a barrier towards them actually participating in your treatment therapies. So asking them, the specifics of what they were given. Was it off a step? Was it bilateral or unilateral? Were you doing it with shoes on? Were you wearing your orthoses when you were using it? What external load? So if they were doing, say, squats, was it 40 kilos, 20 kilos? Just getting a real, like you said, real detailed description of what their previous experience was. And like I said, in relation specifically to certain exercises.
Yeah, definitely, 100%. And then if we go even bigger picture, broader questions, like, and this will lead into our managing expectations side of things, like asking questions right from the start of like, what do you feel like you need right now? So they may have a preconceived like conception of what they feel they need, and so it might be completely different to what you would recommend to them. But you need to sort of meet them in the middle, or you need to manage their expectations by asking questions like, what do you feel like you need? Is there anything that you feel like has contributed to this problem? And in the past, and I think a lot of certainly the new grads and stuff I've been mentoring, they feel like if they ask questions like that, or what do you think is wrong, then the person or the client is going to think that means that you don't know what's going on, and you're asking them, and they've come into you to see you for the solution. So but you got to frame it as well. So ask them, what do you feel like has contributed to this, and what do you feel like you need right now? The reason I'm asking you these questions is so I can get an idea of your understanding, and then we can path a way forward from there. So if you explain as well why you're asking certain questions, that goes a long way too.
Yeah, definitely. And that, I think, is a really good point. So asking what their level of understanding will be, and especially with the musculoskeletal conditions that we treat. So as we know, there's that really big spectrum of tendon and fascia pathologies that people can have. It can either be sort of tenosynovitis, where it's quite inflamed, or it can be into the sort of degenerative tendinopathy, where there may not be really much of a hint of any inflammation present. So asking what their understanding of their condition is, or what they think is actually wrong. So do they think that they have an inflamed tendon that needs cortisone or whatever's happening? Because if you get an idea of where they are, and then you sort of, that's where you can kind of build up their knowledge and information, or the information that you're giving them, to actually get them understanding a little bit better. Because sometimes if they've got this one sort of idea in their head of what's going on, and then you're giving them the completely different set of information, there can be that disconnect between the two. But if you sort of figure out where they are here, and then potentially explain sort of this process, but why they don't have that happening, they've got this happening, you can kind of move them towards that. So definitely figuring out where they're starting from. And that's something that we talk about with even just the prescription of exercise therapies, is we might have an idea of where we want to get them to, whether it's sort of returning back to running or lawn bowls or whatever their activity is. So you have your end point in mind, but then you've got to figure out where they're starting from. And that's where you formulate how you're going to get them from where they are to where they want to be. And it's exactly the same with the history taking. You sort of find out what their level of understanding is initially, and then you have in your head the information that you need and want to convey to them. So then if you find out where they are, where you want to get them, that's how you can sort of do a little bit of re-education and get that mind shift happening for them.
Yeah, definitely. And also asking questions like, how long do you think this is going to take? So, or how, if we started a strength program for you now, so say they're on board with the strengthening, ask them questions like, so if we start this strength program and we build the capacity of your body over a period of time, like how long do you think it's going to take before you're pain-free or before you're back to playing your sport? And then they'll give you your answer, and then you can either agree with them or reframe their expectations there. But it's good to have an idea of where they think, how long they think it's going to take. So then, because you'll have a better idea of actually how long it's going to take. So then you can sort of meet in the middle somewhere and talk it through. So, but you don't know those things unless you ask the question.
Yep, definitely. And do you agree? And this is just one thing that I found, and with one of the lectures I did earlier on in the year with Daniel Goldblum, the orthopedic surgeon in Melbourne, we were having a chat before we went live about expectations, and people like in, say, elite sport, where they've done an ankle syndesmosis injury and they've had surgery, and they really motor through the rehab and they're back playing sport relatively quickly. One, they're young, or youngish, and two, they have a real financial sort of need and a lot of medical and health support to actually get them back on track. Whereas for a lot of other people, and the layperson who may not be as physically active, who has other things happening in their life, doesn't have as much access to the health system, and there may be some financial constraints. What someone might have in their mind, like, oh, so-and-so from whatever footy team, they were back playing sport within 6 weeks, so I should be taking 6 weeks. But realistically, you might know that because of their multitude of risk factors, they're maybe looking at sort of 10 weeks or so. So I do think that the media has a little bit to play into setting some unrealistic expectations.
Yeah, definitely. And just, asking the questions and listening and understanding where they think they're at and how long they think it's going to take is really, really important, because then you can and also reflect back what they say to you. So one of the things that Daniel's taught me is reflective listening. So where like if they tell you a whole bunch of information, if you can repeat it back to them so they know that you've understood and you've listened and you've heard what they've said. And then that builds the trust as well. So I think the subjective history taking section of your appointment is really, really important. And you can spend almost like a half the appointment taking questions. Like I've spent sometimes like a half an hour taking a really decent, even longer. I've spent a whole consult sometimes taking a history and talking to people. So, and that when you reflect back what they've said and you can repeat it and show that you've understood it and you understand them and you want to help them, it actually helps to build rapport. So having a stronger, more deep and thorough subjective history taking really helps with long-term benefits and long-term results. Because I've actually had people before comment on how, oh, you asked so many questions, and that was really that was really personable and that sort of thing. So when you ask all the questions, it really helps with rapport, which helps with outcomes.
Yeah, definitely. And that's even sort of tying back into some of the literature that we're talking about, where people sort of get interrupted by health practitioners. One of the biggest factors that contributes to litigation in healthcare is poor communication. And I think, yeah, the subjective history taking and the rapport building, you're literally just setting the stage for how the entire rest of the treatment process is going to go. And so how long are your initial consults when you're dealing with a more sort of chronic musculoskeletal pathology?
Oh, any musculoskeletal pain or for a new client is 1 hour. So,
yep.
And then in subsequent appointments are 40 minutes. And yeah, any general care or routine, just check-ins, 20 minutes. But yeah, definitely that longer consult time for new musculoskeletal pain clients is super, super vital, because you can go deep on this stuff, and it helps to build that connection and that trust, that therapeutic alliance between you and the client. And yeah, you need the longer time to do that. You can't see a new musculoskeletal client in a 20-minute consult and expect to, figure out what's wrong, give them exercises, talk about all their different options and that sort of thing. You can't do it in 20 minutes.
I agree. There's it's been quite interesting in the, God, how long have I been working for? 14 years, 13, long time. Yeah, like there's been different clinics that I've worked in, and when I had my own, like, as you know, we had the 1 hour initial consults, and where I work with Nitter at Spark, that's also 1 hour initial consults. But there's been other clinics I've worked at where the initial consultations, they're all half an hour. And I found that really, really difficult, especially with what we were just talking about, trying to get that information out of people, especially with the chronic pathologies where it might take them half an hour to tell their story. And it was quite funny, some of the responses I got from the people that were in charge of me a few years back, where it was, oh, you should be able to assess and start a treatment plan and do everything in 30 minutes. And yeah, like I do agree that in that time we might have an idea of what's going on, but it doesn't actually allow the person that we're treating to tell their story. So I think it comes down to, when you have that approach where it's, no, you should be able to get in, get out, figure it out, then start the treatment, which is often orthoses, which I really don't agree with. In that 30 minutes, that's sort of, you're treating the pathology and not the person. And I don't think, especially in chronic conditions, I don't think that works.
Yeah, definitely not. Definitely you need, for your subjective history, you need to give it enough time. And because like I said right at the start, it's in my opinion, it's the most important part of your consultation. Like I remember back in Foster, there was the first time it happened, first client that I ever had, where I was just talking to them for the whole consultation, and I realized at the end, as they were leaving, that I didn't actually touch their feet once. And while some people that might be, they might frown upon that or think that's not good, but it rarely happens. But the first time it did happen, I was like, oh wow, I didn't actually do any assessments. We just had a chat the whole time, but we had a good idea of what we needed to do, what's contributed to the problem, what the plan is going forward, and I gave them a few things to work on. And I didn't actually do any objective assessment. It was all it was all just talking, and it was great that we got good results with that client.
Yeah. Do you remember what the pathology was that you were treating?
It was an chronic Achilles tendinopathy, and yeah, so it's just a long history of Achilles pain. They were in their mid 30s, so but they had a long history of Achilles pain, and they were an endurance runner. And yeah, we just chatted for most of the time.
Yeah, and that's not necessarily a bad thing for two reasons.
Yeah.
One, if we actually look at the literature that it's in relation to the diagnostics of Achilles tendon pathologies.
Yeah.
The only two clinical tests that are the most reliable with the sensitivity and specificity is self-reported location of pain and self-reported morning stiffness. So, and that sort of goes into, that's one of the most common pathologies that we'll treat via telehealth. You can do an Achilles tendinopathy assessment via telehealth, and even in that, you're not actually touching the person as well.
Yeah, for sure. No, that's really reassuring. But yeah, no, I that was the one that sticks out in my mind. The first time it happened, I was like, wow, and that sort of yeah, got me really hyper focused on my subjective history taking. I realized that you can do that, and how powerful it was. Like I took a deep subjective history and really understood everything about what was going on and about them as well. Yeah, asking other questions like, you know, what do they do for work and that sort of thing? You know, what does their daily life look like? So when we're going to prescribe exercises, having an idea of what their day looks like, if they're working, if they've got kids, you know, finding out what time of the day they may have to do exercises. So that's really helpful, rather than just dictating and giving them a set of exercises to do. Say, do this exercise 3 times a day, actually working with the client and figuring out, okay, when are you going to be able to implement this exercise into your day? And you can't figure that out unless you ask those questions, and it all comes back to your subjective history taking.
Yeah, exactly. And it's even, it's like I always bang on about with the prescription of exercise therapies, and like you talk about as well, is it's a collaboration. So if we're dictating to someone who, okay, I don't really care about you, your history, what you like to do, what you don't like to do, you're just going to do these 5 exercises that I've given you 3 times a day. That, if we're not actually understanding the person that we're giving the exercises to, again, that can create a little bit of a barrier for implementation and adherence. So if you find out what they're already doing, so some people, they may already be going to some gym classes, or they just do their own gym activities or whatever. If you, take a good history and find out what they're already doing and what their day is structured like, you can try and incorporate the rehabilitation into fitting in with what they're actually doing. Because if you can do that, that automatically is likely going to increase their adherence to the exercise program.
Yeah, 100%. That's yeah. Again, it just comes down to your subjective history taking. It's massive. Asking the right questions, asking lots of questions, and letting them talk and listen. So going back to that, like not interrupting people, some of the things like I just let them talk, and then if they say, you ask them, how can I help you? And they tell you about their pain in their foot. I've got pain here. It's been happening for this long. It's getting worse. I don't know what to do. And then once they stop, then say end, or say, yep, what else? Ask them questions like what else, or end, or just prompt them to continue in what they're saying, and then they usually find some more information, and it's usually really helpful.
Is that from Tyson?
Yeah. So I heard that in Tyson's podcast, but then I realized that I sort of do that as well, with just asking like what else, or and just let them continue.
Yeah, it makes a huge difference. When I had a chat with Tyson Franklin, I think it was at the start of the year, we were covering that as well. And I tested it, and like you, I think I do that quite often, but I was really conscious for probably a week after of doing that. And it makes a huge difference if you just sort of give them the space and the opportunity to, because they'll keep thinking about it if you give them a little bit of time, and they'll share even more information. And sometimes the information that comes later on in the conversation is actually more pertinent than the information they were sharing at the start.
Yeah, definitely. And how many people have you had that you get through a whole consultation, you think you've done really well and it's gone really well, and then like right at the end, they tell you a new piece of information that just completely changes everything.
Yeah, that happens a lot.
Yeah.
And so tying in with, so there's the subjective history that we'll take at the start. And do you find that, so you'll get towards the end of a consultation, so you've taken this really good detailed history, you've done potentially some assessing, and then you sort of do your education piece, whether or not it's educating about the pathology, what the time frame is, managing their expectations in regards to that, what treatments you may be looking at doing. So do you, like what I tend to do at the end of a consult, and I'm curious if you do this as well. Because there is a lot of information that we can convey in a very short space of time, I tend to, like at the end of it, that maybe this big bulk of information, then summarize it in a few sentences. So, okay, so this is sort of what you've said to me. This is what it looks like is going on. This is what our plan will be. Do you summarize and then get the person to repeat back to you what, so you might go, so what, yeah, now after everything that we've covered, what's your understanding of what you've got going on, what we're going to do, and what the plan is moving forward?
Yeah. And if definitely at the end of the consult, give like a little, spend like 3 or 4 minutes summarizing everything. And I think Dan calls it his serious 5. So like his serious 5 minutes at the end of the consult where we summarize everything and we really make sure that we're on the right page with everything, and then ask them, have I answered all of your questions today? Do you understand what we need to do here? Things like that. And even if you get them to repeat it back to you, but even if you don't do that, definitely at the next consultation, ask them straight away, like what is your understanding, or what do you remember from our last consultation? And see if they've been able to retain that information and understand it well each time. So because each consultation they come into, you need to either re-correct them again, because a lot of the information we give is misinterpreted. So we need to make sure at each consult when they come in, we're both on the same page right from the start. So reframing and re-clarifying and reflecting and getting them to tell you what they understand or what they learnt from their last appointment is really powerful.
Yep, for sure. So if we had to, because there's not too much more I think we have to cover as far as the importance of subjective history taking and sort of the expectations that people can take away from that. So if you had to summarize probably 3 key factors that are really important for someone taking a musculoskeletal history, subjective history, what would you say that they are?
Okay, so ask the right questions. So ask the right questions, ask a lot of questions, and listen and give them time to tell their story. Really, I think that's really important. And it sounds cheesy, right? Let them tell their story, but it's really true. It's really true. It really works, and it makes them feel really comfortable. And definitely listen. That's the other one.
Yeah, or you treat them like a person, and that's going to make the world of difference, I feel.
100%. What about you? What are your main points?
I think definitely find out where they are. So what their initial understanding of everything is, which also ties into tell their story. So find out where they are, find out where they want to be. So what they want to get to. So what their movement goals are, how it's impacting on their life, what they actually want to achieve from the consultation process. So where they are, where they want to be, and then what potential barriers that they have to actually achieving those goals. So they're the things that I think during the subjective history taking are the most important to ascertain.
100%. And definitely for new graduates, just I think it can really be helpful to them as well, because when you have that sort of lower sort of knowledge base, for want of a better term, really understanding what the client wants and the client needs can really help you to dictate what you, or help you to choose what path to take forward if you take the good subjective history.
Definitely. And I think having the individual be part of their own treatment process makes a huge difference. Like I know in my early days, I was very guilty of the fact that I was a little bit of an arrogant shit when I first graduated, and I've done 4 years of uni, I know what you need. And the person might have been quite resistant and I wasn't actually listening to them. And that just, I had a few, this is sort of, 12, 13 years ago. I know that there were some patients that didn't come back because of me not actually listening to them. I was treating the pathology, not the person. So very much as a new grad, there's no harm in, getting a lot of information from a patient and what they're actually wanting to achieve from the treatment. It doesn't mean that you're a bad practitioner or you're not sure about what's going on. It just means that you and the individual can actually work to get on the same page, which it doesn't matter if you're a new grad or you've been practicing for 30 years. You need to get on the same page to have a good outcome.
And it shows that you care as well, and that makes them like you. And that's super important for results, is that rapport building. So,
Oh, 100%.
yeah, definitely. I think that's a good way to wrap up.